Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School here on the Duluth Regional Campus. And I'm your host for the program tonight on upper extremity, neck and back problems. Please call in your questions dealing with a sore neck, back problems, problems with your shoulders, arms, wrists, or hands. Our panelists this evening include Dr. Robert Bejnarowicz, a neurosurgeon with St. Luke's Neurosurgery Associates, Dr. Samuel Harms, an orthopedic surgeon with Orthopaedic Associates of Duluth, and Dr. Brad Kuzel, an orthopedic surgeon with Essentia Health. Our medical students answering the phones tonight are Ryan Emanuelson of Owatonna, Minnesota, Hunter Smith of Zimmerman, Minnesota, and Lauren Summers of Janesville, Minnesota. Please remember the success of this program really depends on you, the viewer. The numbers at the bottom of the screen are for you to call in with your questions, and please we'll do our best to address them. I'd also like to remind you that today is National Rural Health Day for those of you out in the country, and for all of us that take care of rural citizens. It's nice to once in a while get recognized for what we do. So tonight we've got an excellent panel. Dr. Bejnarowicz, do you want to tell us a little bit about yourself?
Sure. Thanks a lot, Ray, for the nice introduction. My name is Robert Bejnarowicz. I'm one of the neurological surgeons at St. Luke's Neurosurgery Associates. I'm a general neurological surgeon, and I practice the full gamut of cranial, spine, and peripheral nerve surgery. I've got an interest in minimally invasive spine, as well as some of the spine technology, spine instrumentation, and general spine trauma.
Great. Well, hopefully the questions will bring some of that out.
I hope so. Let's bring them in.
Yes, you bet. Please call in those kind of questions. Dr. Harms.
Thanks, Ray. Yeah, Sam Harms. I work at Orthopaedic Associates. I specialize in sports medicine, did a one-year fellowship in mostly shoulder, knee, surgery, arthroscopic surgery. I still practice. I still have a relatively general orthopedic practice, so I do some joint replacements.
Do you get a lot of the older athletes, or is it mostly young?
Great combination. Yeah.
Oh, it is. Great.
Yeah, I do take care of a sports team in Hibbing, but I also get a fair number of the weekend warriors that we like to call them around the area.
Dr. Kuzel?
Ray, thanks for having me back. So I'm Brad Kuzel. I'm an orthopedic surgeon at Essentia Health, and my fellowship training is in upper extremity. So that means I did a little extra training in surgeries of the shoulder, elbow, wrist, and hand. I've been here for 6 years now, and my practice has kind of migrated towards a lot of shoulder surgery, so shoulder replacements, rotator cuff repairs, surgeries for instability, but I also still do a fair amount of surgery in the elbow, wrist, and hand, and then general trauma. And when I'm not working, I spend a lot of time with my family, and so AJ and Eddie are watching at home tonight.
Well, I think Sam's kids are probably watching too.
Yeah, Jack's watching as well.
Bob, I want to start out a little bit talking
Sure.
about the neck, and I thought what we'd do as a beginning is to talk about the neck, the shoulder, and the elbow as just being a little basic anatomy as we build for this
Sure.
evening. So you want to talk a little bit about the spine, the cervical spine?
Sure. Well, the spine, if we look at our little cartoon diagram here, the spine is a collection, a series of complex joints. In the cervical spine, we've got 7 joints and 7 segmental levels. The majority of the joint complex, what we refer to the subaxial spine, consists of 3 joints. What that's made up of is a disc, which we see in the front here. So a disc complex, well, what's a disc? A disc is a complex joint that bears the mechanical stress of the body. In this case, it's a wrapper, has around 60 layers of a wrapper, and then the inner portion of that disc is a soft material, something that we call the nucleus. Behind that column, we have the spinal canal. In the low back, it has these individual nerve roots. In the neck, it would have the spinal cord. And then farther behind that, we have the bones that you can reach around and feel in the neck, as well as a ligament. The joint complex in the back, we've got 2 paired joints on the right and then the left side. So the spine itself, the cervical spine, consists of 3 joints at each segment.
Great. Thanks for the review. I hope the medical students were watching that
Let's
too.
hope.
Dr. Kuzel, you want to talk a little bit about the shoulder?
Yeah, so the shoulder, it's my favorite joint. I think the anatomy of the shoulder is very unique. And so when we think about the shoulder and what kind of issues I typically see, probably the most common problem is a rotator cuff injury or rotator cuff tear. That can lead to a lot of pain, problems with sleeping at night, weakness with overhead activity. And so it's something that it's just a very common problem that most of us surgeons take care of. But there's also arthritis. There's a lot of different kinds of arthritis, and so then in that scenario, then sometimes we're thinking about joint replacements. And there's different kinds of joint replacements that we do, depending on the type of arthritis. And then with the young athletes, like a lot, that Sam sees, there can be instability issues from a dislocation or labral tears or injuries like that.
Sam, why don't we move down to the elbow
Yeah.
and talk a little bit. We talked earlier, and I know there's questions coming in on a tennis elbow and golfer's elbow and some of those things, and just give us a little background.
Yeah, those are two of the most common diagnoses that I see in my clinic for elbow pain. And tennis and golfer's elbow are nothing more than tendonitis or tendinopathy, basically some wear and tear or inflammation of the tendons as they attach up around the elbow. Golfer's elbow hurts on the inside part of the elbow, and tennis elbow is more on the outside. Tennis elbow is more common. It's common in people who do a lot of repetitive activity like typing, keyboarding, or more manual laborers, carpenters, electricians, things like that. But it can be a really difficult problem to treat and cure. We try numerous things like injections, a lot of physical therapy, home exercises, and stretching programs.
So we've got to dive into questions. It's always hard to know just where to start, but spinal stenosis, so Bob, we'll go to your area first.
Sure.
Just give us a little background around that.
Well, spinal stenosis, so what is that?
And the best treatment.
The best treatment, and if we're talking about the neck, spinal stenosis, again, what that refers to is narrowing of that spine canal. So if we go back to our little drawing, we're looking at the distance between the front and the back of the spinal canal. So what happens over the years is that spinal cord in the middle of the neck, as a result of overgrowth of the joints on the one side and then the other, that caliber of the spinal canal can get smaller and smaller. So in the neck, spinal stenosis potentially can impinge upon the function of the spinal cord as well as the nerves that exit the neck. In the low back, spinal stenosis, because we now no longer have a spinal cord, we have a collection of nerves. If you can imagine a water tube, that tube is filled with the individual nerves. If you have what's called lumbar or low back spinal stenosis, potentially that would cause problems with the legs. So the treatment, depending on the severity of the stenosis and what the symptoms for the patient, well, the treatment might be your usual non-surgical conservative treatment measures, physical therapy, strengthening exercises, all of these things. But if the stenosis is severe and the patient's symptomatic, then you'd be looking at a potential surgical procedure. And what you're doing in both circumstances, you're trying to decompress that part of the spine to make room for either the spinal cord, the nerves, or in this case in the low back, the spinal canal.
Nice primer. Thank you. Sam, muscles fall asleep. This is a gentleman calling in. His muscles fall asleep, and when he wakes up at night, what can he do about that? And I don't know which muscles.
It's probably not so much the muscles are falling asleep. It sounds like he's having more compression of the nerves in the upper extremity or arm. One of the most common things to get compressed are two of the nerves, your median nerve or ulnar nerve. People recognize those more commonly as carpal tunnel syndrome or cubital tunnel syndrome. And those are often things that will show up or show themselves at night because you're sleeping in one position with your elbow or wrist flexed, and that can predispose you to numbness and tingling in your hand and fingers.
This one, Brad, this one's tough, and I don't know the answer. This is a post-shingles question, and you guys are orthopods, and you might throw me out on this one. I don't know. This gentleman has pain across his right shoulder from the middle of his chest to the middle of his back. Had shingles about 8 years ago, and since then has had pain in that areas. Are there any treatments that you guys as orthopedic surgeons, maybe as a neurosurgeon, have As a family physician, those treatments are really, really tough. So I'm handing it off.
Right, so I think if a patient comes to me with really complex pain or pain that we don't understand, we were talking about this earlier, there's a lot of patients who have shoulder pain, or they feel like they're having shoulder pain, but they could have a pinched nerve in their neck. And so I think we're always trying to think broadly. Is this from his prior experience with shingles, or does he have an issue in his shoulder or a pinched nerve in his thoracic spine? And so I think that would probably be the way that I would address it. I'd want to rule out that there wasn't something that would be potentially treatable before I'd be thinking about shingles. And then if it came to shingles, I probably would consult my friend in primary care about the best treatment.
Yeah. These are tough. They're very, very different. Go get your Shingrix shot. I think that's the best thing I can say right now. Go back to our program from about 2 or 3 weeks ago. Peripheral neuropathies. Anybody want to take that one on? Fingertip numbness. So as we go down, I'll let you guys on the distal end take a look at this.
You should take that one.
Yeah, I suppose I should. So you can have these three, or you can have half of this one and this one. So do you want to talk about those neuropathies just a little bit? And either one of you.
Sure. Well, the neuropathy involves basically irritation, inflammation, something abnormal with the nerve. And there's 3 main nerves that come down into the hand. The radial nerve comes down to the back of the hand. The median nerve does the thumb, index, and long finger sensation. And then the ulnar nerve does most of the sensation to the ring finger and small finger. And peripheral neuropathies typically are a result of diabetes or other inflammatory processes in our bodies that can affect the nerves, or like I mentioned before, compression on the nerves can cause carpal tunnel or cubital tunnel, and they can also give you similar symptoms as the neuropathy.
Brad, is there any medication or supplement for osteoporosis and osteoporotic fractures? You guys see these, I'm pretty sure, a lot with hips and wherever.
Right. I think, well, there's a whole range of medications that can be taken. The standards are calcium and vitamin D, and I think if you're worried about osteoporosis, it's important to have the diagnosis, so have a bone scan to know whether or not it's a milder form called osteopenia or a more severe form called osteoporosis. There are a number of other medications that typically are prescribed by primary care providers or even endocrinologists that can be more effective, but also can have more significant side effects too. And so when patients ask me, one of the things I mention is I think it's really important to stay active. Keep moving. The body in motion is always going to be healthier. The bones are going to be stronger. They like to be used. And also a lot of the programs that are out there, like curves, where there's light weightlifting and resistance training, I think are really effective for keeping bones stronger.
That's right. Just to add, bones like turnover, and so when you use them, you're actually breaking down some bone every time you're using them, and then your body needs to turn over that bone, and that kind of helps regenerate and rebuild it, and that's how you maintain healthy bones long term.
Perfect. Thank you.
And can I add one thing to
Sure.
that? I think especially up here in Duluth, where there's a lot of ice the majority of the year, right? It's important to think about how to prevent the fall too, and sometimes it can be hard to use walkers or canes, but hiking poles. There's a lot of different strategies you can use to prevent the fall. And when a patient has a hip fracture or a wrist fracture, it can be especially hip fractures, it can be a real life-changing event. So if you can prevent that from happening in the first place, I think that's probably one of the keys.
Yak tracks.
Yeah, exactly.
To go with it.
Good traction on your
So
boots.
we'll just do a panel one on this one. It's really kind of Bob's area too, so it's got to do with popping necks, pain when they turn their necks, pain down the arms, and things like that coming from the neck. So maybe if you want to start in on this one and talk to us a little bit. When you turn, you get all these noises, and
Sure.
people are asking about that, and they're asking about popping necks, and then things that might shoot down the arm and things like that. So.
Sure. So the one common question we have is from patients is, I had my neck adjusted and I heard a crack or a pop, or I rotate my head one way or the other and I feel a crack or a pop. And that is fairly common. What that usually is fluid moving in a joint. And so it's an audible pop or a crack, but what can sometimes pair along with that is gritting, clicking, the sound of sandpaper, and that may indicate degeneration of the joint in the neck. Now, if you were to feel a crack or a pop, or you moved a certain way, and then, other than local or what we call focal discomfort in the neck, if you got pain shooting in the arm, what that could herald potentially is irritation of a nerve. And so if we imagine the nerves that come off the spine, well, they eventually head off the neck, pass around the shoulder, under the collarbone, and then into the arm. So if you have irritation of one of those nerves, it could potentially manifest itself as pain in the arm.
Can that happen elsewhere besides from the neck, you guys?
Well, there's something called thoracic outlet syndrome, where it can cause compression of the nerves as they exit the neck, just like Rob was talking about, but they go through some scalene muscles up on the front side of the neck, and occasionally you can get some pinching between the muscles and possibly the first rib. That's not a common diagnosis, but it does occur and can happen.
And I think these joints are really complex, whether you're talking about the spine or the shoulder or the elbow. There's a lot of motion interfaces, and so there's a lot of, even in healthy joints there can be popping, but certainly when you get arthritis there tends to be more. You know, and a good history, a good physical examination are vital when you're trying to determine, so if pain's radiating down the arm, it can be from shoulder pain, from a cuff tear, and a lot of it depends on where the pain is located, what brings on the pain, what makes it worse, what tends to relieve it. And so all these things I think take time, and one of the things that we all do as part of our jobs is spend time listening to our patients, trying to really understand where their pain's coming from, and then we're probably doing a pretty thorough examination, trying to kind of localize it even further, and then we'll also use other things like imaging studies to help us understand.
This person from Duluth has had a right rotator cuff repair and now has right back pain. And there's a lot of back, so I'm not just sure where that would be. The question is this possibly from the surgery? Could that be causing that?
Most likely not directly related to the surgery. The rotator cuff is a group of 4 muscles that surrounds the shoulder, the ball and socket joint of the shoulder. They're not very big muscles, but they're very important, and we consider them the dynamic stabilizers of the shoulder. And they commonly get torn, like Brad talked about earlier. They commonly have wear and tear with them, and we do a lot of repairs. However, the repair process is usually done arthroscopic these days through small poke holes, and just involves the shoulder. And typically if you have recurrent pain related to that, it's usually in the side of the arm or front of the shoulder. Usually it's not referred to the back or low back or mid back. It's probably a secondary problem.
Brad, this person had a right shoulder replacement in July, has stiffness in her shoulder. I don't have an age. She feels that her funny bone is pinched and it goes down to her hand. Is there something she should do about this?
So I think the first thing that I'd recommend is follow up with your surgeon. We always want to know if something's not going right, and you know, we want to make sure that our patients are having a good experience. And so if something's not going right, if you know, for instance, lack of motion could be a number of things. Some people just get stiffer than others during their recovery, and it takes a little bit longer for them. It could be related to how stiff she was before the surgery, but kind of in the worst case scenario, the ball might not be sitting in the right spot in the socket, and a simple x-ray could show that and help diagnose that problem and lead to treatment. With the numbness and tingling that's happening in the ring and small fingers, again, I think I'd recommend seeing the shoulder surgeon, because most shoulder surgeons will take care of that problem as well. And it's a history, a physical examination. And if it's bad enough, there's studies that can be done to investigate, to diagnose it. And so there's a test called an EMG, or nerve conduction test, that can be done to identify if the nerve is pinched, where it's pinched, how bad it's pinched. And there's, you know, that test can be a little challenging sometimes for folks. So there's other options too, like an MSK ultrasound study that can look at the nerve. And so I think there's definitely things that can be done. And
challenging because of the little needles?
Right.
Okay.
Right. But I think a
It's a
follow-up,
good test otherwise.
a follow-up with the surgeon would be the first step.
Yep. Bob, what are titanium cages that are placed on during back surgery, and why? Why are they used?
Titanium cages are a more of a novel approach. What we used to use in between the bone segments, the vertebral segments in the spine, if you can imagine, we've surgically removed the bulk of a disc. So what you have is you've got a segment with nothing supporting it because the bulk of the disc is removed. A titanium cage fits in that space where the disc normally was. So the cage could be a rectangle, it could be a half circle, it could be a longer rectangle, but the idea is to support those two columns of bone in there. The reason that we use that is to augment what we call a fusion procedure. So once a patient has a titanium cage placed in between their vertebral bodies and the spine, it's part of a fusion process.
I'm going to go back to spinal stenosis just for a moment too. I'll pick on you for a little bit. Do injections for pain and spinal stenosis, is there a place for them?
There is, in the low back, there may be a role for injection treatment. Now, injections usually involve a needle, right? The last I checked, yeah. So those are kind of, well, that's a little bit of a scary thing for some people. So there's a couple type of different injections in the back. The most common one that we hear about is something called an epidural injection. So what's an epidural? An epidural is you're placing an anti-inflammatory medication, what we call a corticosteroid, over an inflamed nerve. If a patient had an element of spinal stenosis and had what we call nerve pain or radicular pain, the role of that injection is to decrease the inflammation and thus decrease the pain that's referred to that nerve. If a patient doesn't have pain in their leg, let's say they don't have nerve pain and they just have spinal stenosis, the role of injection may not be as efficacious and a little unclear.
Thank you. Bone spurs, Sam, what are those? What's the treatment? Surgery?
Not always. Bone spurs are typically, when we hear people talk about bone spurs, for example, bone spurs around the shoulder, it typically involves the ball and socket joint in the shoulder. And that's an arthritic or arthritis process. And so osteoarthritis is a wear and tear process to the shoulder. And as the cartilage wears off the joint, just like the tread wears off the tires on your car, our body senses that, and its response is to attempt to make something. However, it can't make new cartilage, it can't replace the cartilage on the bone or in the joint, and so we end up with these bone spurs around there. And they can be rather large and rather debilitating because they can restrict your range of motion and make the joint kind of out of alignment or out of round. And so the treatment typically by itself is not removing the bone spurs. Typically it's a different procedure, like a replacement option.
Brad, we only got a couple, 3 minutes. This might tie us right out. This person's got an aching shoulder. The CAT scan didn't show anything. MRI showed that I didn't have a rotator cuff. It was resorbed. The condition is a reverse rotator repair. Can you explain that? It sounds scary.
So it sounds like this individual has probably had a long-standing rotator cuff tear. And so, as Sam mentioned earlier, there's 4 rotator cuff muscles. A lot of times it's folks will have a small tear, a tear only involving one muscle, but tears can get larger, and it sounds like this individual may have a tear that involves multiple muscles. And there comes a time where the muscles are not repairable. They pull back, the muscles tend to shrink down, and they become a lot less elastic. And in those patients, unfortunately, we can't perform the rotator cuff repair. And then a specific kind of replacement called a reverse shoulder replacement is one of the treatment options. And it was developed in Europe initially, but has been done in the United States now probably 15, 20 years. And it's a very effective tool for patients who have a hard time raising their arm because their tear is so large, for people who are really in severe debilitating pain, again, during the day, at night, affecting their quality of life. And it's a replacement that was done specifically for, or created specifically for patients who have this problem. And instead of relying on the rotator cuff muscles and the deltoid to raise the arm, it's the biomechanics of the replacement kind of created such a situation so that the deltoid can help raise the arm. And so there are patients who really literally can't raise their arm at all. We call it pseudoparalysis. And after the replacement, they can raise their arm up and they have a lot less pain. So it's a very effective tool for those patients.
Thank you. These are really great answers tonight. This has been a busy night. I want to thank our panelists, Dr. Robert Bejnarowicz, Dr. Samuel Harms. I knew I was going to goof it up. Dr. Brad Kuzel, and our medical student phone volunteers, Ryan Emanuelson, Hunter Smith, and Lauren Summers. We will be off the next 2 weeks for Thanksgiving holiday and the public television membership drive. Please remember the drive. Please join Dr. Ann Stephen from Essentia Health in 3 weeks for a program on lower extremity, knee, foot, and hip problems. Her panelists will be Dr. Brad Edgerton, Dr. Heather Groth, and Dr. Catherine Schnell. Thank you so much for watching tonight. Have a great night.